Thanks, Yvonne. Hi, everyone. As Yvonne said, my name's Sam and I work in Guy's and St Thomas's Hospital. I'm a senior BMS there. And at St Thomas's, we have a large cardiac centre and they perform a lot of operations with cardiac patients, plus the paediatric cases with the Evelina Hospital, which is also a part of us. And at Guy's, which is on a separate site, we have a large cancer centre and a haematology day unit. And for all of these things, our transfusion labs support these tests and treatments. So I'm just going to give you an overview today of what I do in the transfusion lab and some of our basic testing. And hopefully at the end of this session, you'll be able to understand the blood transfusion processes in England. I'm going to, hopefully you'll be able to outline some of the components that we use in the blood transfusion laboratory and hopefully recall some of the key steps that are involved in the transfusion testing protocols. So I wanted to start by talking about haemovigilance, which is very important in transfusion. It is a set of surveillance procedures covering the whole transfusion chain, and it covers why testing is so rigorous in transfusion. It covers from the collection of blood and its components to the follow-up of its recipients, plus the ability to collect and assess information on any unexpected or undesirable effects resulting from those blood transfusions. And we want to try and prevent their occurrence and reoccurrence. So the purpose is to detect, report, and prevent any transfusion-related complications and ensure patient safety is covered through the whole transfusion chain. And this is including from blood donation to collection, and then the transfusion in the clinical setting for the patients. And we want to monitor all types of incidents, including those adverse transfusion reactions, near misses, and any errors in blood collection, testing, storage, or administration. So in the UK, we have a number of different regulatory bodies that monitor our laboratories. The first one is the Medicines, Health and Healthcare Products Regulatory Agency, which is shortened to the MHRA. And this regulates blood establishments under the BSQR, which is our blood safety and quality regulations. It ensures compliance with safety, traceability, and quality standards in blood collection, testing, processing, storage, and distribution. And they carry out inspections and grant licenses for the laboratories and the blood establishments. Another regulatory body is our UCAS, which is the United Kingdom Accreditation Service. And this provides accreditation to laboratories, including transfusion labs, but it covers all pathology laboratories against standards such as ISO 1589. So this assesses the technical competency and quality management systems in our pathology services. And it just makes sure that our labs are meeting a high quality standards for testing, accuracy, and also reliability. And as I previously mentioned, as part of haemovigilance, we must be able to report our incidents. So we've got two methods in which we could do that. We've got SABRE, which stands for Serious Adverse Blood Reactions and Events. And this is a mandatory reporting system managed by the MHRA. And it is used to report serious adverse reactions and events related to blood transfusion and donation. And as I said, blood establishments and hospitals must report through SABRE to comply with the BSQR. And then we have a second reporting system, which is SHOT, which is Serious Hazards of Transfusion. And this is the UK's independent haemovigilance scheme. And it collects and analyses data on transfusion-related adverse incidents and near misses. It publishes an annual report to try and highlight risk and provide service improvements and recommendations. So the participation is voluntary, but it is widely supported in the UK because we want to learn from those mistakes and provide self-improvement. And so I wanted to give you a kind of idea of the donation process in the UK. I don't do that part in my lab, but I've got a short video to show you what happens in the blood donation labs. So hopefully that has given you an idea of our blood transfusion system in the UK and the donation process that we use, and also the importance of our external NHSBT laboratories doing the testing for us on those sites. So the testing that they perform at those hospital sites that they mentioned, they'll do the blood transfusion testing, which is the ABO and D grouping and the antibody screening, and also any testing for rare phenotypes as well. But there's also microbiology and virology testing that they do on every single unit, and that's tested every time a person donates. So that includes your hepatitis, your hep C, your syphilis, and depending on your travel history, they will also test for conditions like malaria or West Nile virus to make sure that those units are safe to be given to another patient. So now I'm going to start talking about the different types of components that we have in our laboratory and that we can issue to our patients. And I'm going to start with the one that we probably issue the most, which is our red cells. And as the video stated, they are suitable for storage for up to 35 days once they've been bled from the recipient. And the most common reason for a red cell transfusion can be blood loss. So this can be due to surgery or trauma, or perhaps internal bleeding, anemia, which is sometimes disease related, such as in kidney disease or cancer, or it can be like an iron deficiency anemia that's too severe or unresponsive to other treatment. And also bone marrow disorders like leukemia or aplastic anemia, which then cause anemia in the patient. At our Guy's site especially, we've got a large population of sickle cell disease and thalassemia. So we provide exchange transfusions for those patients to try and prevent complications by improving their oxygen delivery. We have also got our FFP, which is our fresh frozen plasma. And this is frozen at the NHSBT site and delivered to us frozen. And then that is available for 3 years from the donation. And FFP contains coagulation factors. So we would give this product for patients that are having a coagulopathy with bleeding or before surgery, and we want to replace those clotting factors. In patients that have liver disease and they might have factor deficiencies. We also use FFP in our major hemorrhage protocol with red cells and platelets to try and maintain a coagulation balance. And also we might issue it to patients for those that have a factor deficiency if there's no specific factor concentrate available, although we rarely do that due to the availability of those. Moving on to our next frozen product. So this is cryoprecipitate, and cryoprecipitate is once again frozen, so it's available 3 years post donation. Once it's stored, it's only available for 4 hours. And I should mention previously, FFP is only valid for 24 hours once it's stored. So we only store it on request from the clinician. So cryoprecipitate is rich in fibrinogen and it's essential for your clot formation. So you can get low fibrinogen levels, often if you are having a massive transfusion due to a large hemorrhage and you're having a lot of blood products. If you have DIC, which is disseminated intravascular coagulation, so all of your clotting factors are being used up, and often in liver diseases, or if you have a rare inherited fibrinogen deficiency and there's no concentrate available, we could also give cryoprecipitate. We also can give platelets. So platelets are only available sort of 5 to 7 days from donation. So we don't hold that much on site just because of the short expiry of these products. But these platelets are given traditionally when the patient has a low platelet count or thrombocytopenia. And we would give them to try and prevent or treat bleeding when those platelet counts are critically low. We may also, even if they're not bleeding, give them a prophylactic transfusion to prevent spontaneous bleeding. So in conditions such as leukemia or aplastic anemia, or if patients are undergoing chemotherapy, the bone marrow cannot make enough platelets. So we might also give a transfusion to boost their numbers. And as previously mentioned, if the patient is having a major hemorrhage, we would want to use a combination of all of these products to make sure that they've got a balanced and they're not coagulopathic. And the final product that I wanted to talk about is a rare product that we don't issue very often, but it's still part of that donation process, is our granulocytes. So these are white cells, and they are given to patients with severe neutropenia with life-threatening infections. They are only available for 24 hours once they've been processed, so we would order in on a specific patient basis. And most of these patients have a very low neutrophil count, and it's often after chemotherapy or a bone marrow transplant. And they also have a serious bacterial or fungal infection, and they haven't been able to respond to any antibiotics or any antifungals. So I mentioned that granulocyte transfusions are rarely used, and the reason for that, they're often a last resort because of their short shelf life. They must be used very quickly, and they're very expensive to process. There's a high risk of a reaction due to them being white cells present, and there is limited and inconsistent information on the clinical benefit for the patient. So I've done a quick run through of the different components that we use in the transfusion lab. And so the part that starts with us is we would receive a request for one of these components from the clinical teams. All of our requests documented on EPIC, which is our electronic health information system, and they must be ordered by an authorized prescriber. So they must ask for the component that they want and give a genuine reason why they need that component for that patient for us to be able to process the request. Once we would receive the request, we would await some samples to be taken, or there might be samples in the lab already. If samples need to be taken for testing, we require EDTA, which is a whole blood. The blood is anticoagulated for group and save testing. And when we are issuing products, we need to have at least 2 samples tested. One as a historical of the group, and then one as a current to ensure that that blood group matches. Because a ABO incompatible transfusion is a never event and it should never happen. And we need 2 samples to make sure that it's a wrong blood in tube that's been collected. So we are very strict with our samples, and we require 4 demographics. So we need the name, date of birth, MRN, and also it to be dated and timed. And this is very important for sample validity, which I will mention later. So once the samples have been taken by the clinical area, all labelled, we receive them into our lab, into our LIMS system. So group and save testing can be done within 48 hours, but anytime after that, we will reject the samples due to the effects of time on the samples. It could give us erroneous results. We have a zero tolerance policy on our specimen. So if there is any demographic that is incorrect, it would be rejected and we would ask for a new sample. So we have a 2-check system to make sure that we don't miss any mistakes. The first check is when it's booked into our specimen reception and it's booked into our LIMS system. So there'll be one member of staff checking the samples and making sure the request is correct. And then once it's been booked in by that person, it's then second checked by another independent member of staff. And this check is documented on our LIMS system. So every sample that goes through our lab, we can see that 2 pairs of eyes have been on that to make sure that all those demographics are correct. So once the samples have been accepted into our laboratory, they are then centrifuged and they go on our automated analyzers that look like this. So we have Biorad analyzers. We have on the left IH500 and then on the right an IH1000. So these machines can do a lot of different tests, but the one that we do a lot of and is probably the most tested in blood transfusion is our group and screen test. So we want to identify the blood group of the patient, which is the group part, and we screen the patient's plasma for any alloantibodies present. So this is done for those patients that may need a transfusion or antenatal serology. So when we think about our red cells, we think that they look like this. Our red cells are lovely biconcave discs that look quite simple. No nucleus. This is the perception of red cells that we have. So although this is an animation, it does demonstrate that these red cells are very complicated beings, just like many other cell types in the human body. So in blood transfusion, there are 9 clinically significant antigen groups that we would be testing for. And the antigens also have a functional role within the cell, helping the structural integrity and the transport systems for the cell. So the combination of all of these antigens that people have on their cell surface can vary depending on a number of factors, including genetics. And the distribution of blood types can vary in different populations around the world, meaning that sourcing blood for patients with very specific characteristics can sometimes be problematic when there are no donors available. So currently, there are 36 known blood group systems, and the most clinically important are your ABO and RH. And this is because antigens on any donor red cells can stimulate a patient to produce an antibody if the patient lacks the antigens themselves. So the likelihood of this antibody production is low, but it does increase the more transfusions that are given. So in the blood transfusion lab, the majority of our testing is based around antigen-antibody complexes. And we use the formation of these complexes to identify if the antigens or antibodies are present within the patient. So we test the known against the unknown. And much of this testing is now automated and is performed on the analyzers that I showed you previously, but it has the same principles when we do the testing manually. And this is why we can't rush the testing, as it undergoes many different stages with specific timeframes. So now I'm going to talk to you a bit about the testing. So I'm going to break down the group and the screen. And so, as I said, we firstly centrifuge our samples as we require both the red cells and the plasma. And in our serology testing, we use column agglutination technology in our cards, which relies on those antibody-antigen complex formations. So with our grouping testing, we want to find out the patient's blood group. Therefore, we use the patient's red cells to see what antigens are present on them. And this is known as our forward group. So this is the first 4 wells seen in that card. That is your forward group, and we would put a dilution of red cells into those, and it's got known anti-sera present in those wells. And the reverse group is the second part of that card, is used to identify which antibodies are present in the plasma. So ABO is the only blood group system in which the antibodies naturally occur. And from this, we will see that if the patient has the antigen on their red cell surface, they will not create the antibody. So you can see that in this example, the positive reaction is the one at the top, because those antigen-antibody complexes are formed and they've not been able to drop through the gel. So the B well is positive. So that means this patient has the B antigen on their red cells, and they have got the A antibody in their plasma. So the 2 should correspond. So just going a bit further into blood groups, I've just got an example of each one. So if you're not aware, we've got our O, A, B, and AB blood groups. And on the O blood group, there are no antigens on the red cell surface. And this is why we often see this as a universal donor, because it doesn't have any of those A or B antigens present on the red cell surface. And if you look below at the testing results, you can see that their anti-A and anti-B in the first 2 wells are completely negative. But then on the flip side, they do have the anti-A1 and the anti-B in their plasma. AB is the complete reverse. so that they have A and B on their red cell surface, but they don't carry any of those antibodies, apologies, in their plasma. So O is often seen as the universal donor for red cells, and then AB is often seen the universal donor for plasma products. And then going on to the RHD, so we often hear many people say patients O pos or O neg. So this is the pos or neg part of the group, so the RHD group. And you either have it or you don't. It's easy as that. And we test for it the same way as we would an ABO group. And RH is the second most clinically significant blood group after ABO, and this is why we test for it. So as you can see, you either have it or you don't. There isn't a in between. And in these situations, it's therefore fine to transfuse an RHD positive patient with RHD negative blood, as they are completely lacking the antigen and they cannot form an immune response. So O neg is often seen as our emergency flying squad because it doesn't have any A or B antigen, and it also doesn't carry the RHD antigen either. So we found out what's present on the patient's red cells. So we've identified their blood group. We then use the plasma to screen for the presence of red cell alloantibodies. And we want to find these because they are capable of causing a transfusion reaction in those 9 major blood groups. The reagents that we use are donor cells that are selected from the suppliers, and each patient will have a selection of antigens that they are positive or negative for. Due to the complexity of the red cells, as I demonstrated earlier with the animation, they've not yet been able to supply us with reagents with independent antigens. Therefore, we've got to do a bit of investigation to try and figure out the patterns. So to perform our antibody screening, we use the red cell reagents and the patient's plasma, and then this is incubated at 37 degrees. And this is because this is our body temperature, because we want to see what is reacting within the body. And these cards are then centrifuged. And it uses, once again, those antigen-antibody complexes. So the antibody screening is performed using a panel of red cells that contains the examples of clinically important blood groups most often seen in practice, and it's normally 3 cells because it's a screen. As you can see from the diagram at the bottom, we've got lots of different positives and negatives, so that's just what that reagent is positive and negative for those blood groups. So as this is just a screen, if we get a positive result, we would need to do a lot of further investigation to identify the antibody specificity. When the screen is positive, it just helps us identify which ones will need further testing to identify those antibodies, and it enables us to select suitable units if required. So we like to do this screen. Most of our patients will have a negative screen, but about, I think it's 3 to 5% have an allo antibody. So reporting of a positive screen also will alert the clinician that there might be a possible delay in units because we might not have compatible blood on site. So when we do an antibody panel, this is the second step on from the initial screen. And as you can see, there's a lot more cells that are now available with the positives and negatives for us to be able to try and investigate and identify what they have made. So a failure to recognize all of the antibody specificities within a sample may lead to a hemolytic transfusion reaction. So when we identify one specificity, it's essential that we make sure that the presence or absence of additional significant antibodies is also established, because a lot of patients will have multiple antibodies. If there is any doubt concerning the identity of any of the antibodies present, or we can't exclude any clinically significant antibodies, we are able to send the blood sample off to one of our red cell reference laboratories. And because they are reference center, they have access to a number of different techniques and rare reagents to try and identify those antibodies. But with this, because it's off-site, it may be at a delay and require a lot of sample to do the initial investigation. So we have done all of our testing on our samples. We've done our group and our antibody screen, and we have managed to identify, hopefully, any antibodies in-house, meaning that we have got to the point where we can go back to our request and we can try and select some components to issue to those patients. So before we issue the units, there are a number of checks that we perform to make sure we select those units. So we want to check the results from the samples, so the group and screen, and the antibody screen and identification. And all of this is saved in our computer system, in our LIMS system. So we then want to establish their cross-match status. So can we do an electronic issue, which I'll discuss later, or is it going to be a full serological cross-match? And also as well, we want to look at their other haematology results to see if it is actually a request that is genuine and it's not an unnecessary transfusion for the patient. If we deem it unnecessary, we would escalate that within our clinical haematology team to make sure that the patient isn't receiving any unnecessary products. We would then move on to special requirements. So there are some patients that require special requirements for their blood. So we can irradiate the blood, which is treating it with gamma rays. And we do this for patients at risk of graft versus host disease. So it could be that they're on a certain type of medication, they've had a bone marrow transplant or a lymphoma. We can, as part of the testing at the National Blood Service, they also screen for CMV negative. So we would select a CMV negative unit for pregnant women or neonates. And also for those patients that need specialist blood, so phenotype specific, so they need very specific blood for one of those other 9 clinically significant blood groups, we would identify if we've got those units available in stock. So we do all these checks when we've got the request to make sure that we've got suitable units in our stock fridges. And if not, we would order these in from the National Blood Centre and it would be delivered on their next routine run. So the stock of rare units are normally held at those centres and then we would request them when required. If there is any potential delay due to a specialist unit being needed, we would obviously tell the clinical area to let them know that there could be a potential delay to their patient's transfusion. So in blood transfusion, sample validity is very important and we're very strict on that. So samples are valid for 3 days if the patient's been transfused or is pregnant within the last 3 months. Or if they've not been transfused or pregnant within the last 3 months, they have 7 days to be able to ask for blood, and we would issue it within that time from that sample being taken. So in blood transfusion, we are very strict on our sample validity rules for the issues of the blood products, because antibody development can occur after a transfusion or in pregnancy. So if they have had this in their history, it will shorten their sample validity because we want to make sure that they've not developed anything new since their last transfusion. And this 3-day rule just ensures that we have an up-to-date antibody screen and it's safer for the compatibility testing for finding those units. So when we go to think about how we're going to give units to a patient, there are a few different methods of compatibility that we can use. So the first one that we can use is an emergency issue. So in the laboratory, we would never deny access to any blood provision, but in an emergency situation, we would provide uncross-matched bloods. And this means that we haven't been able to do any of those pre-compatibility checks that we would usually do. So we haven't had any samples, or we're unsure of special requirements, etc. But because of this, it's a clinical decision whether the blood is required and should be decided on a risk-benefit ratio. So any delays to blood provision in emergency can cause a patient harm. So at our trust, we have flying squad dotted all around the hospital in our satellite fridges. and we can also issue the units from the laboratory if required. So if it is an emergency and you do need blood, but you haven't supplied us with samples, you can still get blood, but it is a clinical decision to transfuse. Our second most, emergency issue we don't use very often because a lot of our patients are cardiac patients, which are having pre-planned operations, or they are coming in for a top-up from the Haematology Day Unit or the Cancer Centre. So a lot of our patients, we can provide blood via electronic issue. And this is sometimes known as computer cross-matching. And most hospitals use this type of issue the majority of the time because it's a safe and rapid technique. And it relies on the fact that the patient's ABO and RHD groups are reliably established. And this is because we've tested it twice and we know that it's correct from that patient. And a sensitive antibody screen is negative. So this is why it's so important that those 9 clinically significant blood groups are screened for. And if it is negative, we can do this computer cross-match. And this is because the possibility of issuing incompatible blood is negligible because we've done all of our checks beforehand. So if the lab does do electronic issue, it follows strict criteria set out by the BSH guidelines, such as the testing and result entry are fully automated. And this is to try and mitigate the potential for any human error in this process because we know that that's a risk factor. Also, the laboratory information system, our computer system, can identify that there are compatible units in the blood stock inventory in our blood stock system on the site without the need for further testing. For those patients that are not eligible for an electronic issue for a computer cross-match, we must perform a full serological cross-match. So this can be slightly longer than issuing blood via the computer cross-match method, but it just ensures that we are doing everything to check that it is compatible with the patient. So this is what we used to do with all of our units before the computers came in. And it's now the final step in providing a safe blood to carry out this cross-match between the patient's plasma and a sample of the red cells of the donor unit selected for transfusion. So we would make patient's plasma and the unit we've selected. So we perform this slightly antibody screen at 37 degrees, and we're looking for any evidence that there is a reaction that could possibly indicate an incompatibility. If there is an incompatibility, that would highlight to us that that unit is not compatible, and we would not select that unit for transfusion. The test that we do is used to detect the ABO and non-ABO red cells incompatibility between the donor cells and the plasma, and we test the donor units, each donor unit against the intended recipient. So we've done all of our compatibility. We've taken the request, we've tested our samples, and we've selected our units, and we've done the compatibility. So the final step is our component labeling, and our labels are printed directly from our LIMS system. So it has all the patient demographics on there. And in the blood transfusion lab, our verification and component labeling crucial for ensuring patient safety and the correct transfusion of blood products. So what we should be checking during this step, this is our final check before it goes into the fridge. We are checking our patient details, our component information, our special requirements. So this is everything that we've done previously. We'll be doing our final checks. We'll be just checking our storage information. So depending on the product, depends on the storage requirement. So the red cells will go in the fridge, or the platelets will go in an agitator. And we also use barcode scanners to ensure the electronic verification that the tag matches that unit. And this is to reduce our human error. So ensuring that all of these details are correct in this component label verification step helps minimize the risk of transfusion errors and ultimately improves patient safety. So the final part, we've put our unit in the fridge. It's been labeled correctly, and it's there waiting for the unit to be picked up. So we have a system, it's all electronically tracked for the timing. So the key features of these systems are the fact that The units have real-time identification and verification of the blood products and the temperature and time tracking for the storage and transport conditions, which is really important. Going back to hemovigilance and RBSQR, it's really important that we are able to monitor those units at all times to make sure that we can trace them. Also, through these systems, we get real-time notifications for if there's any incorrect matches on the ward. So if they try and put up an incorrect unit on the incorrect patient, that would alert us in the lab. And it also tells us if any products are expiring, it will give alerts. And it tracks its journey out of the fridge until it reaches the ward, another fridge, or once it's been transfused. So this process ensures a safe, traceable, and efficient transfusion practice and ultimately minimizes errors. So in summary, I've covered a lot today, but hopefully I've given you a introduction to how we work in the UK and basics on the lab. So we've covered a little bit on hemovigilance, about who regulates us, the components that we are able to transfuse, as well as some information on the laboratory on our pre-transfusion checks and our component selection. So thank you for listening. Have you got any questions?
Thank you, Samantha. That's very interesting. Any questions from the Zambia side, please? It's probably very different from what you do there. Dr.
Good
Sahar.
afternoon. I just want to find out about the white blood cells transfusion. How frequent do you use it? Do you really use it, or because we know that it causes too much reaction and we don't have this facility in Zambia?
So do you mean blood requests? How many blood requests do we get?
The
or...
white blood cells.
For
Like
white blood cell
granules-
transfusions.
Oh,
granulous
white.
How often do we do that? Because Dr. Sahar is saying they don't do that in Zambia because of the risk, yeah.
So we
How
definitely don't use
frequent
it.
is yeah.
I would say it's definitely based on the patient. It doesn't happen very frequently in our lab. So I've been at Guy's and St Thomas's for about 5 years now. And I think during my time there, there's been about 6 patients over the time that have used granulocytes. As I said, it's normally sort of a last resort, and it takes a lot of approval. So it goes through the consultants and the registrars, but it would be a course of 5 days as well. The units are also very expensive to process. So each unit is over £1,000, and they get 2 units a day over 5 days. And the clinical benefit is unknown. But we do it rarely, but we do offer that on site, those granulocyte transfusions.
There you go, Dr. Sahar. Last ditch resort and costs a lot of money.
Yeah.
Okay, thank you.
Any other questions from anybody? How does that compare to what you do there in general?
And I hear they tell you the manual method for detection of blood group and the compatibility testing, even comps tests. So it's still on the manual side, but we have the platelet transfusion, we have the cryoprecipitate fresh frozen plasma. So like we have different category of blood component transfusion, but not the granulocyte.
Yeah. You have a very good blood bank because I visited it.
Yeah.
Yeah.
And now even the concentrated platelets using the platelet apheresis also is very helpful for a lot of patients. Yeah,
But
better than
that's in Lusaka. What about in the rest of the country? Can they get that everywhere else or just in Lusaka?
I think there is another province that they have another machine, but I'm not sure where exactly. Yeah.
Okay. Thank you. Well, if
Thank
there's
you.
no questions, thank you very much, Samantha. Hope